and welcome. I'm Steve Clemens. I'm editor-at-large of The Hill. Thanks so much for joining us for our program today called The New Role of Telehealth, an in-depth discussion on improving patient care and the role of telemedicine in our healthcare system. I'd like to thank our sponsor, Neurocrine Biosciences, for making this event possible. The explosion of telehealth has been a lifesaver for many during the pandemic, allowing patients to check in with doctors regularly while avoiding crowded emergency rooms. But the digital divide and the inability to diagnose certain conditions remotely has also created challenges for both physicians and patients adjusting to a more virtual world. So where's the balance right? We've got to figure this out. As we assess the future of telehealth, how do we strike that right balance between virtual and in-person patient care? And how do we ensure the highest quality of care for every patient? We've got a fantastic lineup of speakers here today to answer these questions and much more. Before we get underway, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag #TheHillTelehealth. We're broadcasting live and we'll take your questions throughout the program. And if you experience any trouble with the live stream, please refresh the page and that will fix all the problems, or that's what they tell me. My first guest of the afternoon is Congressman Brad Schneider, who represents Illinois' 10th District. He's a member of the Ways and Means Health Subcommittee. Representative Schneider, it's great to see you. Look, I mean, I think that one of the things I'm fascinated by is, I've been doing conversations on health for a long time and also the digital age that's coming. But the pandemic literally changed our lives so much where so much of our daily life experience, our work, our connections with family members, and our connections with the health profession have gone digitally. Where do you think we're getting it right? Where do you think we're getting it wrong in this new digital telehealth space?
Well, Steve, first, it's good to be with you. Thanks for having me on the program. And you're absolutely right. We are seeing a dramatic shift in the way telephony is being used in general and telehealth in particular. The pandemic forced many medical practices, many physicians and others to rely on the ability to do, whether it's a Zoom call or whatever platform, to meet with their patients, to engage in that care. The way I describe it is that prior to the pandemic, there were a lot of people who were anywhere on the spectrum from doubtful to skeptical to curious about telehealth. I think post-pandemic, we're all very enthusiastic about its possibilities. But you're also right, we have to find the right balance, and it's not going to be static. Doctors will develop new approaches in taking care of their patients. They'll develop relationships, but it will be a supplement, certainly, to what we're doing in healthcare.
When you are interacting with your constituents and you're out in the field and talking to people, what are some of the stories you're hearing, about this kind of conversation? And, when I'm trying to sort of look at what the public policy side of this ought to look like, because I do know on one hand there's been a lot of surprise at how amazing and empowering telehealth has been for some, and there's a little bit of worry that it may be wobbly depending on how Medicare reimbursement goes down the road. But then I know a lot of other folks have ailments. They said, hey, we don't want to get left behind in that next new brave world coming along.
Right. So I've heard the full spectrum, as you touched on it. The people who have used telehealth, both providers and patients, have very much appreciated the opportunity. What it means is the ability to see a doctor. If someone who lives in a remote location can get to that doctor instantaneously without having to drive an hour or longer for an appointment. It means cut down on wait times. It means access to specialists. All of that is very positive. But I've also heard from the medical professionals, they're seeing many more patients. It's expanded their capacity and capabilities, but they want to make sure that they're being fairly reimbursed for the time they spend with their patients.
Can you tell us a little bit more about broadband accessibility and what it's like in your district? I mean, it's some of the things that comes up so often in all of my conversations, both sides of the aisle, senators, House members. And I guess to tell you, as an American, I live on the net, but I mean, I just find it one of the most staggeringly ridiculous elements of this country that we have so many people that can't connect. What's the story in your district?
Yeah, it's the same that we're seeing across the country. Broadband is the electricity of 100 years ago, where it is the distinction of, are you a part of the modern world or are you being held back? My district, which is the suburbs of Chicago, northern suburbs, certain areas have incredible access to high-speed internet, as much bandwidth as they could possibly desire. Other places are lagging far behind. From the first stories we started hearing when the schools went to remote is that there were areas where people had to go park their cars outside of public libraries or other places. Some school districts were renting school buses with hotspots to go into areas to provide access to that educational resource. But it's the same is true. If you can't get on for school, you're not getting on for your doctor. So we need to make sure that every community has access to broadband. That's why it was a part of the American Rescue Plan. It's a part of the infrastructure plan that hopefully will be passed soon to continue to expand the broadband's reach so that in the same way we take for granted wherever we go, we can flip a switch and turn on the lights, that we can turn our devices and connect with our doctors, our teachers, or our family members.
So there's a lot in that big reconciliation bill. There's a lot in there about human infrastructure. As you just talked, there may be everything from kind of expanding Medicare to include dental benefits to whatever. Can I just ask you from your insights, because, a lot of us have not read, the kind of light item, parts of what's in that bill. On the health side of this, what do you think is solid and secure in the legislation that's pending? What do you think could be on the chopping block?
Yeah, so everything's on the table right now being negotiated, but I think there are certain things that we need to make sure are part of whatever package goes forward. Broadband, as we discussed, is part of the infrastructure bill, an expansion of broadband, making sure we're getting it to all of our communities, whether those are urban or rural communities, that everyone can rely on that robust access to whether it's telemedicine or whatever form of telecommunications. But it's also expanding access to care. Making sure that everyone in this country can have health care as a right, not as a privilege. We have a number of bills that will invest in, you mentioned expansion of Medicare. There's talk of expanding it for vision, dental, and hearing. We'll see which of those survive. I think there's going to be a lot of negotiations. What are the basic things we need to be looking for? One is the basic access to care, and that's why broadband and telemedicine is so important in that piece. We want to continue to provide more physicians and healthcare professionals. We know that there are many places around the country that are suffering. I have legislation that would expand access to residencies so that more hospitals can educate the doctors for the future. As well, not a part of the reconciliation, but I'll be introducing a bill this week, bipartisan legislation with Brad Westrup of Ohio, that will, in the same way last year, or in the last Congress, we introduced legislation for high deductible health plans to guarantee everyone at least 2 visits to a primary care physician. This new bill would provide at least 2 telemedicine visits in every high deductible health plan. So at least everyone is getting that basic health care, building the relationship with the doctor, and the chance that they do need more significant care, they have a relationship already established.
Look, today's topic is very interesting to me because, part of it is to look at the reality that telehealth has expanded. There's another dimension, though. What is the right equilibrium, kind of tell people there. And it just makes me think about that, I've talked to a lot of doctors. I know a lot of, colleagues of yours that are doctors in the so-called doctors caucus. And, a lot of times people in the public don't understand the economic and financial stress that the medical profession itself is under. And I'm just wondering, as efficiencies are created for both the patient, for citizens, and efficiencies created for the medical sector, the physician sector, there is still this need of kind of in-person people out there. And I know this is not your job, but I'm just wondering, do we have a brewing public policy problem about getting that balance right, that the hospitals, the providers, the others out there, may not have the same kind of economic foundation they may have had before telehealth became so expansive?
Right. Well, I'll shift play with words a little bit and call it a challenge more than a problem. It is going to be a challenge. How do we find that right balance? I don't think telehealth is going to completely replace in-person medicine. For example, a year and a half ago, my son, I guess just over a year ago, my son had a bike accident, hurt his arm. The care he needed, the surgery, you can't operate on a separated shoulder through telehealth. But the ongoing care, the rehabilitation, the checking on status, telehealth absolutely is going to play a role in that. And, the holy grail is trying to find the right balance of how to get efficiencies, efficacies, and a fair pricing on all of this. We'll have that same question on telehealth. It's not going to replace in-person care. It's going to supplement in-person care. It should make the system more efficient and effective. We got to make sure that those cost savings are passed to patients, but that the doctors are rightly and fairly compensated for their work as well.
Hey, I want to go to an audience question in a minute that we have for you, but I'm going to ask you another silly. I used to work in the United States Senate, and I worked for Senator Jeff Bingaman of New Mexico. He was a very smart guy, but he wasn't smart on everything. And so we would have kind of teach-ins. You had to kind of tool up on various stuff. I've been always interested in what the literacy level of members of Congress and, senators are when it comes to the increasing complexity of health questions. And what's coming to mind today is a very smart guy is retiring. Francis Collins, director of the National Institutes of Health, is retiring today. And Francis, Dr. Collins used to go up and spend a lot of time kind of tooling up, helping members of Congress tool up on all these issues. I'm just interested in how you do it, not what I don't, not whether you would give somebody an A to a D or something in there, but the process by which all of you up there continue to refresh, update, understand the complexity of these health issues that you're being asked to weigh in on.
That's a wonderful point you're making. Look, we all come from wherever we come. There's 435 districts. Each one is distinct. We bring distinct experiences, everything from lawyers to doctors to people in business to educators, et cetera. Some of us come in with a narrow but deep understanding of a few things. Some of us come in with a very broad but less deep understanding of a lot of things. But no one comes in understanding everything about everything. We need to learn that along the way. So it starts with making sure you surround yourself with a really good team. I have an amazing staff who goes deep on these issues. Part of my job as representative, I have to listen to all of the different voices in my district. I have a district which has a very high concentration of healthcare, of what I call the life sciences corridor. So I'm fortunate in that respect that I can talk to constituents, both individuals and some of the corporate leaders in our community, and get an understanding of the different aspects of it. But at the end of the day, these are big, complex issues that we have to spend the time studying and understanding to get our heads around, but also know that even when we think we have an answer, we're going to dig deeper and find that no answer is complete or comprehensive, and constantly be willing to adjust our perspective.
Fascinating. I appreciate your candor on that. It's like one of the things, you wonder how the sausage is being made. Look, we have a question for you from Marguerite. Marguerite?
Hello, my name is Marguerite Pridgeon. I'm the Director of Federal Policy for the Corporation for Supportive Housing, or CSH. I have several questions for the panelists. What barriers exist to accessing telehealth services, especially with respect to availability and use of technology required to provide services? Is there data showing where COVID-19 telehealth funding has had the most impact?
So I guess the question is twofold. One, data about COVID-19 telehealth services and availability from your perspective. And, what are the barriers, which you've gotten into a little bit, but what are the barriers to telehealth expansion in these areas?
So let me first touch on the data, because I think that's important. The first line data, top line data, is that the use of telehealth has exploded during COVID, not surprising to anyone. But if you talk to a medical practice, to a hospital, and look at their numbers, what their projections for telehealth visits in 2020 were off by orders of magnitude. It wasn't that they doubled, but they went up 10 and 20 and 30 times during the course of the pandemic out of necessity. And the same way, look, I'm talking to you on Zoom. 2 years ago, I'd never used Zoom before. This will be my fifth call of the day, and by the time I'm done, I'll probably have 10. I think everyone is experiencing that. But if you dig deeper into the data, what's important to understand is how is it being used, where is it being most effective, how can we expand on that effectiveness, but also where are there gaps and where are we missing? And that is the next level of study. So the data is there. I think the analysis is taking place currently. But one thing that's very clear, there are some very obvious gaps. I touched on some of them, places where broadband just isn't acceptable, or isn't available, rather. If you don't have broadband, you don't have telehealth. And so we need to make sure that we're expanding that broadband. But it's also places where there's reluctance, resistance to use new technologies. Some of the data shows that it's not just about, the first assumption is that the older you are, the less comfortable you might be with technologies. That's not necessarily the case. But there are barriers to technology hesitancy, technology fear of technology, and we've got to overcome that. And then the next piece is it's one thing to be able to have, I'm talking on an iPad here, you got to have access to the devices, But I think as we move forward into the next generation of healthcare, we're going to see that there are increasingly more sophisticated, more advanced devices that will be a part of that telehealth package. But we may have to make sure everyone has access to those as well.
Cox, so I'm going to sneak in a little one. I interviewed a while back Senator Joe Manchin, and he's much in the news of late. And at that time, it's before the big drama of the moment. And I asked him about, it's like during the election, I asked him about Medicare for all. And he said, Steve, Medicare for all, we can't afford Medicare for some. And so I guess my question is, among your colleagues, is there a sense of gravity in terms of the debt figures, of looking at the added obligations, the government, these kinds of issues? Does that come up in the kind of caucus that you're in? Or is there, and I hate to use the word disregard, and I don't really mean it that strongly, is there a version that at this moment, given the needs and inflection point in America, given the divides on race and inequality, that we just have to use this as an inflection point and not worry, and debt be damned? Where are you on that?
So I can give you a personal answer, but I also have the benefit. I'm a part of several different caucuses. So from my personal standpoint, one of the reasons I ran for Congress 10 years ago, the first time, is we need to provide our kids a stable and secure future. And part of that is fiscal responsibility. That's why I'm a Blue Dog. I'm a part of the Blue Dog Caucus. I'm a part of the Problem Solvers Caucus, which is bipartisan, 29 Democrats, 29 Republicans. I'm in leadership of the New Democrat Coalition, which are 95 of the pro-growth, more moderate Democrats. I can promise you we talk about these issues day in and day out. We need to provide health care to all Americans. It should be a right, not a privilege for every single American. We need to bend the curve on the cost of health care. We're spending upwards of 2 or 3 times per capita on health care what other developed countries are spending. And we're not necessarily getting better results. Some areas we're leading, but other areas we're trailing. So I think there's a lot we can do to look at how we deliver health care, how we develop the resources and capabilities to ensure that all of us have the quality of living the life expectancy we all aspire to, and over that life expectancy have the best health and healthcare possible. But there's no question we have to do it in a fiscally sound and fiscally responsible way.
Well, listen, we're going to end it there. But Representative Brad Schneider, thanks so much for your candor and sharing those thoughts with us today. And I'm glad you're in there, wrestling with these issues in real time. Thank you very much for joining us.
Thank you. It's great being with you. It's a privilege to be working on these issues. These are the challenges we face as a country, and working together, I have no doubt we can tackle the challenge.
Thank you. And now it's time for the sponsor perspective portion of our program. Boy, I'm blowing on some of this stuff, but I want to just say a big hello to our sponsor today, Neurocrine, not Neurocrine. I got that a little bit off earlier, so my apologies. But please welcome Kendra Martello, the Executive Director of Public Policy at Neurocrine Biosciences, who's in conversation with Linda Mims, board member of the Schizophrenia and Psychosis Action Alliance, and Randy Ruta, CEO of the National Health Council.
Thanks, Steve. My name is Kendra Martello, and I'm the Executive Director for Public Policy at Neurocrine Biosciences. We're a neuroscience-focused biopharmaceutical company dedicated to discovering treatments for people with serious and under-addressed disorders. Since the early days of the pandemic, we've examined how doctors and patients use telehealth to continue care and the impact of the rapid expansion of telehealth on our patients, those who are living with or at risk of developing an involuntary movement disorder known as tardive dyskinesia. Through that process, the data and information we've compiled has shown us a great deal about key measures such as access and quality of care in telehealth, and that's helped inform our perspectives. This panel today has been convened to discuss the important role of telehealth in patient care and the need for a balanced approach going forward. Today, I'm joined by Linda Mims, board member of the Schizophrenia and Psychosis Action Alliance, and Randy Ruta, CEO of the National Health Council. Their biographies can be found on the event page. Panelists, thank you for joining me today.
Thank you.
Earlier this year, we partnered with the Harris Poll to learn more about patient preference and telehealth. Specifically, we found that while people love the convenience of telehealth, they also value seeing their doctor in person. In fact, 80% of respondents said they would always pick an in-person visit over a telehealth visit. Linda, for persons with mental health conditions, Telehealth presents important considerations between convenience and quality. They sometimes require or request therapy right away, and that can often be effectively done via telehealth. But when it comes to things such as diagnosing movement disorders and other conditions often associated with serious mental illness, that can't be done effectively via telehealth. Can you elaborate on this a bit more and explain how you'd recommend we strike the right balance?
Yes, people living with serious mental illnesses or serious brain disorders are already on the bottom rung of the healthcare ladder when it comes to accessing quality care. This makes it vital that future telehealth standards protect this marginalized population. While many mental health advocacy organizations seek to reduce or eliminate existing telemental health requirements, there is a strong clinical justification for retaining requirements for patients living with schizophrenia and related disorders, bipolar disorder, and major depression. So we must never sacrifice the quality of medical care for the convenience of using telemedicine. Movement disorders are hard to diagnose. Heart disease and diabetes, which are already routinely overlooked in this population and contribute to a 10 to 20 year or more shortened lifespan, those things cannot always be diagnosed or most never can on the internet. So diminished communication skills also in this patient group often lead to unreported symptoms, and providers frequently ascribe all symptoms to the person's serious brain disorder. So these facts make it imperative that strong safeguards are built into any regulations on the future use of telehealth, including periodic in-person office visits.
Randy, I'd like to get your thoughts here as well. Your organization represents a much broader set of persons beyond those living with serious mental illness. For patients with chronic conditions, sometimes there's trial and error in terms of getting the right diagnosis or even treatment. Patients may experience flare-ups, and many times their condition is well managed. From your perspective, how can telehealth and in-person care be most effectively used?
Thank you, Kendra, and great points, Linda. Telehealth is an important tool for people with chronic conditions and disabilities. And for decades, telehealth in various forms has extended the reach of clinical expertise into the home. In listening sessions that the National Health Council conducted recently, we heard very positive things about telehealth from our patient group members, specifically as it related to them being able to support their constituents through the pandemic. How could they manage their chronic conditions with telehealth being either the primary or supplemental source of their care, while the pandemic threatened their ability to be out in the community. However, telehealth programs need to be structured well so that it doesn't inadvertently increase disparities and that it's flexible to address an individual's needs based on their specific condition. And that's key. It shouldn't be the only option for people seeking care. And your question is a good one in that it highlights that different patients will have different needs, and some will have different needs over the course of managing their health in concert with their conditions, so that we know it could be good for, telehealth could be good for, helping triage individuals to determine the best venue and schedule for care, in person or telehealth, for follow-up visits, for routine and maintenance visits for those whose chronic care is well managed. And telehealth could be a supplemental source of support to the clinician and the patient, but not be a substitution overall. Patients and providers need the tools to determine when the patient is best served to come in for a visit or when a visit via telehealth is appropriate, so that clinician consultation with a physician is key to understand when telehealth is the right course for that patient at that time.
Thank you. One final question for you both. We can all agree telehealth has many benefits, and as such, it's important that it remain part of our healthcare system. There are also areas, however, where it may not be the best option. What are 3 things lawmakers should consider as they weigh long-term telehealth policy? Linda, we'll start with you.
Well, lawmakers first and foremost must safeguard the highest standards of medical care when formulating regulations for the use of telehealth. The convenience of using this platform must be balanced by evidence-based outcomes. We have all seen how the exponential growth of new technologies over our lifetime have outpaced regulations to rein in inappropriate use. So healthcare is one arena where we absolutely cannot afford to let this happen. Federal and state lawmakers need to keep in mind that technology in and of itself is not the goal here, but fostering relationships between care providers and patients to achieve optimal treatment and save lives is the top objective. So telehealth is a tool, as Randy was saying, that should be used to complement, not replace in-person care. And any laws governing its usage must be comprehensive in scope. Patchwork laws will not do it. Regulations should ensure a balance between in-person and virtual care and include these provisions. Providers must see their patients in person in designated intervals to ensure that patients receive the screening, diagnosis, and care they need. And Congress should work to maintain patient protections for those living with mental illnesses or serious brain disorders. And then comprehensive training programs for providers for the use of telehealth platforms must be mandated and help, because providers need guidance on how best to interact with people over the internet and diagnose their state of health. And then lastly, regulations must ensure that reimbursement rates for telehealth services are adequate and fair in both Medicare and private insurance coverage. And the Centers for Medicare and Medicaid need to continue reimbursement for audio-only sessions. So telehealth can be a great tool in our continuum of care toolbox as long as guardrails are built in upfront, built into the law to protect patients and providers and ensure the highest standard of care for everyone. After all, isn't that what we are all working for?
Kendra, I'll jump in. I couldn't agree with Linda more. I'll just make my 3 points succinct. So demand for telehealth is here to stay. We know that policymakers have got to work together to maintain this as an option, but as an option. We know that we can't have one-size-fits-all policy solutions because one-size-fits-all doesn't work for healthcare and the best interests of patients. So telehealth, like all aspects of healthcare, has got to be patient-centered and physician-guided and informed. We also know that money can be a real driver in healthcare. So the right incentives through payment policies need to be in place to encourage providers to invest in the needed tools that provide telehealth services, while at the same time not overly incentivizing telehealth over other areas of healthcare delivery, because again, it's got to be the patient and their needs that's determining where that venue of care occurs. And then lastly, we need to be able to allow providers to see patients that may live in states other than where that provider is located. That is the one theme that came up in every conversation with our patient groups with regard to their constituencies. Oftentimes patients who have rare conditions or challenging conditions don't have providers who are nearby. So the state and federal government absolutely should be encouraged to allow patients to access providers that are outside of where they live, the state that they live in, but that we want to make sure that that's done in a way that continues to safeguard the safety and best interests of that patient and provide against fraud and abuse. So those would be 3 points I would encourage lawmakers to examine as they look to improve and sustain telemedicine options.
Well, thank you both very much for your time and your perspectives today. While telehealth policy long-term is not currently actively under consideration, it does remain an important area for Congress and legislators to address. And so we hope that this conversation will help be part of that discussion. Thank you again, and thanks for your time today.
Conversations. Now it's the time for the panel. Amy Brin is the Executive Director and CEO of the Child Neurology Foundation. She's been working with special needs youth and their families for over 2 decades. Dr. David Charles is the Medical Director at Vanderbilt Telehealth. He's been measuring physician and patient satisfaction with telehealth and comparing results to in-person care. And finally, Karen Jones is the President and CEO of the National Caucus and Center on Black Aging. It is the only national organization devoted solely to providing effective leadership in making minority participation in aging services a a national issue and priority. Big welcome to you all. Karen, let me just start with you. I mean, I spend a lot of time with my friend Nancy Lamont of AARP, and I always worry about what are we getting right. When we talk about diversity and inclusion, I look at generational inclusion in these questions as a major priority that needs to be more front and center in a lot of these conversations. As we're discussing telehealth's opportunities and telehealth's limits, where does the population, particularly the population of color who is elder, I hate the words aged, but our moms, dads, us, me, where are they in that picture?
And me. First of all, thanks for having me. Well, particularly since we just went through almost 2 years now of COVID-19, telehealth became very, very important in communities of color and certainly for older adults. Obviously, there were some difficulties because, number one, a lot of older adults don't have access to internet either, or they don't know how to navigate that whole process. And so there had to be some quick learning, or you had to have a grandchild or somebody to come over and help you because it was the only way in the beginning that doctors were seeing their patients. So we realize now that, they've been talking about telehealth for a long time. We knew it was there. It just hadn't had the kind of impact and the kind of, reach that it has now since we've gone through COVID. So it's an important measure. It's an important thing that we need to really try to seek, but it can't be effective if we still have areas that don't have broadband access, if we're not being able to give people access to the internet so that they can do these. And then, as we've heard before, it's very important that we don't replace telehealth with actual meeting with their providers. As that communication and that contact are very important to developing trust in the healthcare system.
Karen, I want to ask you one more notch. I'd love to get David and Amy's reaction to it. I'm not going to mention the pharmacy, but a nationally branded pharmacy I was at, when I was off getting my vaccination, there was a gentleman, I talked to him, he was about 82 years old, but he had his wits about him, he knew what he's doing. And he said, look, he was trying to tell the internist or the person that was sitting in front processing people, I've been told to, call this number. I've been told to get online, which I've been trying to do on my phone, been trying to do it over and over and over again. So this elderly black gentleman had shown up and he said, my wife and I don't know how to do this. And they said, well, just keep, the guy just said, well, just keep at it. And I'm like going, where is the human face here? We're trying to get people of color in the door, to get them in the process. And I guess my question, and it's a little bit of question about where the equilibrium is right, and how do we maintain a human face, a human connection with the people we're trying to serve, as a lot more of it's digital, but we don't lose people in that process. And I mean, this really impacted me, and I got so angry that day, and I mean, this person was given his instructions on how to process people who showed up without an appointment. But I kind of went up as far as I could the chain to help this couple to get their vaccinations, get by. But they just seem to me to be representative of a very large part of the population that sometimes we don't think about when we're thinking about the efficiency. So sorry to get on a soapbox here, but really wonder what you think. And I'd love to go to David and Amy. We have a lot to talk about and cover here, but I'd love to get their thoughts on, who are we leaving behind as we talk about this? But please go ahead, Karen.
Well, just a real quick thing. You had one person, we had hundreds calling and saying, I can't navigate the system. I can't get an appointment. I can't, how do I do this? And so access, again, was one of the health disparities that we continue to see in this country, access that wasn't even put in place. It obviously got a lot better as we moved on in getting the testing and the vaccine sites in place and putting them in communities where people didn't have to go through an internet process to get an appointment. So we had a rough start getting, in the beginning, but it got better, and it certainly is good now where people can go and get that vaccine. As far as where we go from here, that's important. We've always had a health access issue, particularly for communities of color. And that's another reason why there's a lot of distrust, hesitancy, and things that we're trying to deal with to make sure that everybody gets this vaccine so that we can get back to real normal lives. And so those are the things we have to take into consideration. You can't just put something out there, but it has to be where you understand that everybody does not have access to be able to get to an internet. And then, of course, the broadband issue is a real problem.
Thank you, Amy Brand. I'd love to get your thoughts on that. But as you're dealing with children with neurologic conditions as well, what is how does that come in? And are there opportunities with these new platforms that are coming on? And we're going to get to David in just a moment. But what are the limits? How to get the right balance?
Yeah, thanks so much, Steve, for letting me join the conversation. So when we talk about children living with neurologic conditions in the United States, we're talking about 20% of our children. And that can be really a range of conditions, from everything from ADHD to autism to epilepsy to very rare medically complex conditions like spinal muscular atrophy. Pre-COVID, our community's wait time to access a child neurologist was 9 weeks. With the advent or the beginning of the greater use of telehealth, that dropped down to a week, with 20% of our families getting access to care that same day. So the amount of access has definitely exploded for our families that are not part of the digital divide. And to be very frank, our healthcare system pre-COVID was fractured. Telehealth has just illuminated another broken bridge for the families that are really living in underserved communities. What we know is those families living in underserved communities, they're accessing telehealth at remarkably lower rates than those in other communities. And not just because they don't have access to technology or broadband, but it's really illuminating new social determinants of health. So if a family, for example, does not have food, they're not going to prioritize accessing their doctor's appointment. Their first worry is, how are they going to access food? And if they don't have the technology right now during a pandemic to access local community resources that have all also gone virtual, that chasm has just, deepened. And so we are really looking at not only how can we help families relearn and be empowered to use the tool of telehealth, but we are also really looking at how can telehealth be, this is a term I like, but be a reset for this population. So like I said, this is 20% of our children, but they're 80% of the pediatric healthcare expenditure. This is a very costly population. So how can we look at the tool of telehealth as a way to not only provide more accessible and quality care, but really actually more cost-effective care?
Amy, just before I leave you and then jump to David to get his insights on this, are you worried that, I don't know how to put this, I've tried to talk to Representative Brad Schneider about this, but are you worried that the community you serve can be left behind or displaced as we develop these new platforms? We're talking about how to get the equities right and to create a holistic health system that reaches, everyone where they are in this process. But are you worried that decisions that are being made in the public policy space broadly are going to be detrimental to the community you serve?
So it's almost like you were sitting in my recent board meeting. Yes, we are very concerned about that. When you even look at current legislation that's out, there's a complete chasm when you're talking about the pediatric population, especially the pediatric population with special healthcare needs. The models that are being looked at, it's really about adults living with chronic disease. And it's, as your earlier speaker said, this is not one size fits all. There needs to be a balanced perspective. But really, I would urge our policymakers to please engage with us thought leaders, multi-stakeholders, our physicians, our families, our advocates, our researchers, to understand the complexity of this so we get it right. Because we do have an opportunity as a country to get this right now.
Well, let's jump to David Charles. Dr. Charles, you must have been a very busy guy this last couple of years and seen, a virtual explosion. I mean, it's very hard, I think, to underestimate how massive this has become. And I hear the worries, on the other side of people worrying that the Telehealth Foundation and reimbursability, all of this plugins in terms of Medicare will somehow come apart down the road. And so I know that you're probably there. Tell us the picture from your viewpoint. You've heard our conversation. What are the strengths of these new platforms in telehealth? Where do you think we've got room to grow and improve? And what are the limits?
Well, again, Steve, thanks for including me in today's panel. So, I'm a practicing neurologist at Vanderbilt University in Nashville, Tennessee. And for the last 8 or more years, I've served also as our medical director for telehealth here.
Right.
And as we came into the pandemic, in the United States, March of 2020, within 8 days, we trained over 3,000 physicians and staff in the use of telehealth. And we went to doing more telehealth visits per day than we did in the entire prior year. So this technology obviously has made healthcare accessible to so many more people who have socioeconomic challenges that prevent them from missing work to get to a physician's office can now see their physician or clinician via telehealth and also be able to be there to pick up their child from school or from childcare.
Right.
So it's been an incredible transformation. But I really agree with your former panel in that not every visit is right for telehealth. I don't think we need a one-size-fits-all system that says every patient has to be seen every certain number of months via telehealth, because that one-size-fits-all system doesn't fit all geographies, doesn't fit all patient types or age groups. But what we've learned at Vanderbilt is that it's very clear that the in-person visit and making that personal connection with the patient is absolutely vital. Once that connection is made, telehealth becomes an incredible tool to be able to assess patients remotely. I'll share a story with you. So I had a patient, 71 years old, lives 4 hours from Nashville by car. He's had a liver transplant in the past. My team and my physicians were following him for a problem of numbness and tingling in his feet, and he needed an annual checkup for that and a medication renewal. At the end of the visit, I asked him, I said, Mr. Johnson, how did you like having this telehealth visit? And he's like, Dr. Charles, I'm never coming back unless I need to be seen in person. He said, this saved an entire day of my life, 4 hours of driving over, checking into the clinic, being seen for a 20-minute visit, and then the return home. And so for that particular visit, the patient and the physician determined that telehealth was the right choice for that visit. Not for every visit, but for that visit. And the savings and the efficiency are incredible.
It's fascinating, and I want to ask you another question because you sort of got at it. And I don't know, I really don't. Sometimes I ask questions and I know the answers to them. Sometimes I ask questions I don't know the answers. But I was talking to a pollster, Frank Luntz, and Frank was kind of looking at COVID-19 and vaccine trust and whatnot. And we had a couple of doctors of the Doctors Caucus. So Congressman Brad Wenstrup of Ohio. I also talked to Senator John Barrasso of Wyoming, who were saying, patients out there don't want to hear from the federal government. They trust mostly their local doctor, their family doctor. And I think you find this across different communities in the country. And I guess my question is, I don't know if anybody has measured trust in the telehealth space. How is trust faring in the telehealth space versus in person? Do you have any ideas in that? Any thoughts?
I do. So it's a very timely question. In fact, we just did an analysis on this in our neurology clinics. And what we found was that patient satisfaction and the likelihood that they would recommend their physician or clinician or recommend telehealth, the satisfaction for the telehealth visit is on par and in some cases better than the in-person visit. Now, the patients in some clinics in certain disease states, such as ALS, those that may suffer from MS, they may value that in-person visit more than the telehealth visit. That's why I agree with your other panel that a one-size-fits-all doesn't work for this. But absolutely, the in-person visit is critical to the overall care of the patient, establishing that physician-patient relationship and trust. But we're finding the satisfaction with telehealth is strong. It was strong when this first started in March through May of 2020. We just repeated the data March to May 2021, and patient satisfaction and physician satisfaction is remarkably high.
Well, look, we've got two really good questions from our audience for all of you, but I want to slip in one quick one to Karen. Karen, when we talk a lot about the impact on healthcare, I mean, I would ask this of Amy as well, of any population that is not in the mainstream of getting all the services they deserve, but communities that have not for whatever reason. How do we best reach them? How do we best solve this gap? I mean, I talk about this gap where we look at the gap, we study the gap, we see difference in health outcomes and health disparity. What's the silver bullet to fix it? Maybe silver bullet's the wrong metaphor in this case.
Well, it's not a matter of a silver bullet. It's a matter of acknowledgement that we still live in a country where there is racial discrimination, poverty, and all the issues that create what we're talking about in terms of lack of access. So until we acknowledge that everyone doesn't have access to health insurance, everyone doesn't have access to just daily needs such as food and a place to live and what have you, when we acknowledge that and understand that we all have a responsibility to address those, then we can see where the silver bullet is and how we can work on changing that. So, the disparities that we see in health and which affects a lot of things in different society, we're going to see those until we acknowledge the real issue.
Dr. Brin, Amy, I would ask you a similar question. I look at the youth you work with and serve, and it's very moving what you do, and I just find it, I've learned a lot from reading about you and your work. But do we have the right safety nets out there for the young people that have the disorders you're trying to give help and support to, or are there a lot of people not in those safety nets?
Yeah, I would unfortunately say that we have forgotten our children and our youth. And for an advocate, I don't think there's a bigger deal in life to do than to protect and serve the children and the youth of our world. What I would say, though, is I'm a Pollyanna. I believe that sometimes less is more. And I think to really engage with those that are forgotten, whether it's my community or it's Karen's or it's those in East Nashville, it's about collaboration. It's about not owning that the problem is all yours, but to acknowledge we are one and this is a problem for all of us. And how can we collaborate with stakeholders and partners that do have a good, trusted relationship with those that are forgotten and can help us listen and really understand their needs so that the solutions we put forth actually make sense and actually have an impact. These are long-standing issues. There is no quick fix. The only thing we can do, I think, is really to be committed to being good stewards of service and to listen and then to act.
Got it. I love that. Thank you for that. We've got a question here from Paul Kelly, and I'm going to direct it first to Dr. David. Paul?
Hi, Paul Kelly here with Capital Advocacy and Government Affairs. I want to thank Steve and the folks at Hill Newspaper again for having a terrific webinar. I wanted to ask about hands-on care. So much of quality healthcare is hands-on, and I'm wondering, in the face of telehealth, if there's a way to ensure that we continue to have hands-on care while also not sacrificing any of the benefits and convenience of telehealth. Thanks a lot.
Paul, thank you. Charles, go ahead.
Out here at Vanderbilt, patients and the physicians work together to choose what's the right next visit. Should it be in person? Should it be via telehealth? And if the patient wants an in-person visit, we do an in-person visit, period. If the physician feels that the visit needs to be in person, we do an in-person visit. It's only if both the patient and the physician agree that virtual care would be an adequate way to carry out the visit. And so I don't think either side wants to take away the in-person visit. Here's what I would say, turn it upside down. What we can't have is payer policy requiring a patient to have a telehealth visit when they want or their physician wants an in-person visit. Right, so that's the policy that I would be most concerned about. I don't think we need the federal government telling us that every X number of days an in-person visit has to occur, because like the previous panel said, a one-size-fits-all sort of mandate like that from the federal government, it's not really practical to implement. So keeping that decision, the in-person visit with the patient and the physician, right? I believe that's where that decision belongs, and that the patient should have the ability to have that in-person visit if they or their physician want it.
So before I leave you, David, I just want to ask you one little bit, and this may go back to Amy and Karen a little bit, but I'm being told by my producers we don't have a lot of time. But I just want to tell you, and a lot of people I know, and I'm one of these people, I'm not a health aficionado. I'm not someone who is as literate as I should be. I really depend on doctors to tell me kind of what to do. My level of understanding of a lot, I mean, I try to dig in for these, but when I'm, kind of dealing with my doctor, I say, Dr. Patel, I'll do whatever you tell me to do. So there's a lot of power in the relationship that exists with the medical establishment. People are looking for direction and guidance. Maybe that power and that agency needs to shift, but I think it's going to take a while. Is there a problem in the power relationship shifting when as we're looking at this difference between these different modalities in health, or am I Pollyannish, to go back to what Amy said?
Well, I would say where the biggest shift has occurred is that when the patient and the physician are in the room and the door is closed, sometimes it feels like there's a creepy third person in the room. Someone who is watching the decisions that the patient and the physician are making, and then as soon as they leave the room, they're trying to unspool those decisions. If it's a medication that I've prescribed or a test that I recommend. And so if that patient and that physician just decide they need an in-person visit, then they need to have full access to having that in-person visit. Similarly, if both agree that a virtual visit for that particular day, that particular problem is appropriate, then they should be able to choose that as well.
Well, I'm going to go to Amy and Karen in a minute. First, I'm going to get a question in from Jonathan Williams in California. Jonathan?
I'd like to ask about the connections between behavioral health and telehealth. We know that we're dealing with significant behavioral health challenges across the country, and virtual care has opened up a whole new set of options providing mental health and addiction support. My system, Sutter Health in Northern California, over the last 18 months, 90% of our outpatient behavioral health visits have shifted to virtual care, and no-show rates have decreased to 5%. I'd love your thoughts on how telehealth is addressing the behavioral health needs in this country, and what do we need to do to ensure that these needs are addressed equitably? Thank you very much.
A terrific question. So the question is really on mental health, where these platforms can help, what the limits are. Let's go to Amy.
Well, let's hope that's one of the resets, because we obviously know there's a huge lack of access to mental health providers. And the backdrop of this is the pandemic, where we saw so many services get immediately cut off before providers could rotate onto telehealth. And so you had families really living with mental and behavioral health issues, particularly in our population, that became even more isolated. And we saw really a dramatic increase in acute events. And so, yes, this is a complete example of how increased access to telehealth and increased access to providers that don't have to reside within the same state, for example, as the patient, creates new lanes of access. I would also, though, again, always advocate that access isn't the only determinant of good care. How are we ensuring that behavioral health interventions are really quality-based, really focused on the patient's needs, and not just determined by some arbitrary matrix? I think when we're thinking about resets, we've got to think about it from access and quality.
Well, thank you. And Karen, I'd love to get your thoughts in closing in both of these questions, both about, to Jonathan's question about the mental health dimensions of this and how to be smarter, and then finally, about this question of agency, because I imagine many of your members are also trying to sort of navigate that power relationship in a lot of this. What would give them the most help and support?
Well, we're very concerned about our older adults who are suffering from dementia and Alzheimer's, and also the ones just because of the isolation that it created new mental health problems and issues. So it was a real concern for us. And so telehealth would have played a major role in helping a lot of the participants in our program that we work with. I wanted to, when we talk about the federal government not being able to mandate things, I just also wanted to throw in there that fortunately, insurance companies need to take a role into making sure that they're not requiring that there be so many telehealth and so many inpatients. It's not always a government-imposed guideline that makes access to these services a problem. And so I just wanted to throw that out there. But we certainly are concerned about behavioral health, how this affects it. And I'm a big proponent that it should be a patient, health provider decision on when you go in person and when you can do telehealth, and then we'll build up that trust and stop all this hesitancy that we get confronted with when we have to really deal with something like, let's say, COVID-19. it was just a distrust factor. And we're trying to build up trust between the healthcare profession and also our patients. So.
Well, listen, thank you. And we lost David Charles's connection for a minute, but I just thought we just had a very human conversation about how to get these equities right in the whole health challenges that we have. So I really want to thank Dr. David Charles, Medical Director at Vanderbilt Health, Amy Brin, Executive Director and CEO of the Child Neurology Foundation, and Karen Jones, President and CEO of the National Caucus and Center on Black Aging. Thank you all so much.
Thank you, Steve. Have a good day.
And now we're joined by Congressman Brett Guthrie, who represents Kentucky's 2nd District. He spent a lot of time dealing with the intricacies of telehealth services, both as ranking member of the Energy and Commerce Subcommittee on Health and the co-lead of the Healthy Futures Task Force. Representative Guthrie, it's great to be with you. Look, Kevin McCarthy asked you to take on this role of looking at the Healthy Futures Task Force. And I've always liked that framing of what goes in under that tent of health. And it's evolving. We've had a pandemic hit this country hard in so many different ways. We've learned from it in some places. We haven't learned from it in others. But when it comes to healthy futures, what are the equities you think we need to focus on more than we are and to getting the health picture of average Americans? I mean, most Americans, right?
Well, we're looking at a couple of things. One, as we come together, and we're building that the hope that there'll be a Republican majority in the House in 2022. And so what are the things that we can do that we can accomplish? And we're completely aware, most of us are, if not all of us, that President Biden will be president for at least the next couple of years if we're in the majority. So what kind of things can we do together? We're going to have to work together to get things signed into law. It can't just be a partisan push to move forward. So we can do a lot of things. Telehealth being the number one. I think everybody has accepted that we need to move forward with telehealth. Other things, drug pricing, depends on what happens in the reconciliation bill. But if they don't do a lot of drug pricing in the reconciliation bill, there's a lot of bipartisan stuff in drug pricing we can do. We can do Medicare Part D reform, where every senior over 65 will get an out-of-pocket cap. We'll go a long way to help with the expensive pharmaceuticals. The other things we can do is bring generics to the marketplace quicker so that we'll have competition for the more expensive pharmaceuticals. What we don't want to do is limit the investment or kill innovation in these types of drugs moving forward. Another thing I've worked with Kurt Schrader on is value-based agreements. So we're looking at, one, what can we do over the next 2 years? But yes, we need to look at what the future of healthcare is, and it's personalized. We don't want to get between the physician and the patient. We want to improve healthcare and be innovative. And so the current situation, and if you look at the reconciliation bill, the big push for healthcare, it's as big as the Affordable Care Act in spending, but the big push is to make tax credits permanent for people to buy health insurance. And so what we seem to be doing is buying into the system that we want everybody to be covered, but we're going to, whatever health insurance costs, we're just going to subsidize people to be able to afford to have it. And I don't think that's sustainable. I think I always say it follows the image, the same image or the same metaphor as college tuition, that as college tuition goes up, we subsidize people to pay for it. As we subsidize people to pay for it, it goes up. And so we're getting into this cycle, I think, of unsustainable healthcare costs, and it's finally going to break the bank. And so those are things we want to focus on as we move forward. But the immediate future is things that we can do immediately, telehealth being in the top category, that we can do bipartisan, that the president and will be President Biden will sign.
It's fascinating that you started in a kind of way with the Venn diagram of where the interests overlap and kind of come in. Do some of your colleagues on the Democratic side, do you see them doing the same thing, or do you see them pushing beyond that Venn diagram?
Well, I think if you look at the reconciliation bill, there's things in there like H.R. 3 and some other things which is the price setting of pharmaceuticals. A lot of people say it's negotiations, but we can get into the details of that if you don't. But yeah, a lot of us have. A lot of us worked on what we call H.R. 19, which I think you probably get close to unanimous vote out of Energy and Commerce if that was the bill instead of H.R. 3, which does lower drug prices. We know that just doesn't go the direction that they want to go. So there's opportunities to do so. Kurt Schrader and I, who's a Democrat from Oregon, have worked on value-based agreements. I know Anna Esch, you and I agreed to have a hearing, as we did last April or March, last spring in 2021 on telehealth. So there is a lot of opportunities for us to work together.
Well, thank you. You know, one of the things is, we're talking about today and got it behind me on the marker is telehealth. And I guess if we were to kind of roll back 18 months ago and sort of have this program and conversation back then, telehealth was on people's minds, but it hadn't happened. I mean, it happened in bits and spurts, but we've seen just massive shift. And, massive shift so much that people are worried about, is it going to be reimbursable in the future? How wobbly is the ecosystem around telehealth? But it's here to stay. But I was fascinated by comments you made, Congressman, in March. And that's always the worry. Your statements get remembered forever. And so on telehealth, you made very interesting comments to me that kind of covered the whole gamut. You said, look, telehealth, really important, really great development. It has helped so many people achieve health. But there's some parts of it that don't fix everything. Folks with movement disorders, folks that don't have broadband, which we can't forget that a lot of the country is still not connected, which is, I think, a national shame, but we can talk about that. And then lastly, you talked about something as well, which is fraud. So I'm interested in how you see the gains in telehealth and what is the dark side and what is the gray area of folks we can't forget, can't, kind of become so rah-rah about, one dimension in this that we leave a lot of people behind.
Well, great. That's perfect. And yes, we always talked about telehealth, how much easier it would be. And if anything, sometimes when you have tragedies and you have tough situations, some good things come out of the tough situation. And one is that it immediately forced Department of HHS and others to relax rules on telehealth because we had people that needed to see a physician, needed to see a healthcare provider, but we didn't want them going to the healthcare provider and being exposed to COVID. So telehealth came about, but it did expose some things that we have to move forward. One, it makes it easier for people to see a healthcare provider. I live in Kentucky. I live in Bowling Green, which is I live right off I-65, and anybody within any close distance to where I live has access to wonderful healthcare. But I represent some rural counties as well, where you're an hour and a half away. And if you're going to get routine or other types of healthcare, it's just convenient and it gives people access to healthcare. And so we can't put the genie back in the bottle and go back to the way that we were. But how do we move forward and what things do we have to address? One is the parity of payments. So if you're seeing somebody through a telehealth, is it the same cost if you see someone in your office? We need to look at that and see what the parity is. We want it to be properly utilized, because utilization will go up. So if people are having to drive to a healthcare provider to have healthcare, not everybody can get there, not everybody can be there. And so healthcare is going to go up. But if it's somebody that needs the care and they're not getting it because they can't get there, we want the utilization to go up so those people can be served. But also we have to look at the cost impact of that. We don't want overutilization, which that can move forward. You all talked about broadband. I will tell you, even if the reconciliation bill does not pass, I've had people tell me, FCC commissioners, others, there is now enough money in the system through the CARES Act, the American Rescue Plan. The money that went directly to counties. I can tell you my area, most counties are wanting to do broadband. If you were in the broadband installation business, you're going to be busy over the next several years. And the question really is not the money to move it forward, how we're going to have the capacity to move it forward. So not everybody's going to have access to broadband. So what platforms can they use? Can people just FaceTime if they're going to do telehealth? Currently that's not the preferred way to do it, but is that the only way to do it? And so those are the kind of things that we have to look at. The other is licensure. Most states are based on, healthcare providers are licensed by states. And I got into athletic healthcare providers that travel with their teams. I had a friend who was a team doctor for Auburn when they're playing in California. Does he have a license to treat an Auburn player on the sidelines if he's in California? And it took us forever to get that figured out. So the licensure side of it is not going to be easy either. So we want telehealth. We want people to have access to telehealth. We want people that weren't going to the physician because they couldn't get there or a healthcare provider to have access to telehealth. But we have to be mindful of those things as well.
I guess one of the other dimensions, and look, I want to be very careful what I'm going to say so I don't get sued. I signed up for a telehealth experience. I had a great experience, in this. What I did not know, and it's my fault, I was inattentive to detail, is that I had signed up to a club. And I began getting charged every month, even though I probably talk to a doctor twice a year because I'm not, in the area. So, it was interesting where I saw both the benefits, but I worried, wow, there are a lot of people who are less attentive than I am to stuff. who made this. I won't call that fraud. And I'll call it kind of an arrangement where, as this is evolving and as we get norms and practices and habits, they're there. But you were specifically speaking in March about the growth of fraud in telehealth, which really interested me. And I have family in Kentucky, and I know that that there are players out there preying, particularly on elder Americans broadly. But do we have to do something in the policy world about that? Are you worried about that?
I'm glad you brought that up. I'm not sure the situation you talked about is fraud, as you said, but it is something we absolutely have to be mindful of. But we also have to be mindful of fraud, because if you're going to your healthcare provider and they're seeing you personally, there's a record that you're there. People can make those things up. I get there's fraud in traditional Medicare and Medicaid as well. The Medicare we're kind of focusing on. So that happens, but it's harder to do fraud if you're physically moving forward. But if you look at any time we've opened a new program, be it DME, medical equipment, durable medical equipment, there's always seems to be rampant fraud. And so what we're concerned about is the telehealth marketers, where you're getting a phone call from a physician, call this number, we'll provide you with some kind of service, and it just gets billed to Medicare. And so we're looking at things like, you do have to have a visit to the healthcare provider before you can do telehealth moving forward. Those are some of the gatekeepers, just to keep phone banks from developing to call you and offer you advice, and then medical advice that you may not even be soliciting, and then billing the government for what they did. And so we have to have those safeguards in place. And another thing with across state lines is, I think you remember, I had some people here that I know that live in Northern Virginia, and they moved to their parents' home in Alabama because they wanted to, because their kids could go to school. Well, their pediatrician's still in Virginia, so you have to be able to go across state lines if you have a previous relationship such as that. So we have to work with those things as well. So my point is, we all want telehealth, but there have to be some guardrails around it to make sure people aren't taken advantage of, and the government and the taxpayers aren't taking advantage of.
Congressman, another area that you talked about, which I think we're going to be talking about in this program today, are folks with movement disorders, other things where telehealth just one size doesn't fit all, and how to take into account. But there's really another dimension of this, which is really the level, whether telehealth will easily and quickly replace the level of trust between a local doctor and a person. I don't know if you're talking to some of my friends in the Doctors Caucus in the House. There's Brad Wenstrup, there's Senator John Barrasso. There are people on both sides of the aisle that are doctors, and they've talked about during the pandemic that one way to get people to take the vaccine is not have the federal government saying it, but work through trusted ambassadors who are your local doctors, your family doctors. Do you worry about that dimension, that in-person care is going to somehow, and the trust? I mean, we already have trust problems with science and health in this country, let's be honest. And so I guess the question is, if you lay on this new layer that is expanding rapidly, and I find it fascinating and important, but are we losing something in the process?
Well, I think we have to have that patient-doctor relationship. And so the question that you get to that we'll have to answer is, telehealth something that you sign on and you have a cold or you have some issue, so you sign on to telehealth, a physician shows up and you have that diagnosis back and forth. My vision of it, but that's something we have to talk about, and that's why you have hearings and debate, is that you have a relationship with your physician, and then when you need, because there's times, all of us have, I've had children, you have a relationship with a pediatrician, you call that the pediatrician on the phone. Of course, they don't get reimbursed for this kind of stuff, but you call them on the phone and say, Caroline has an earache, whatever, what should I do? And you get advice back that way. So I kind of see it, the way I see it kind of developing is, you have a relationship with your neurologist if it's motion disorders, neurologists for other reasons. And you do have to go to the office on occasion. It's not a pure telehealth relationship, but there are things that you can do back and forth, your monthly checkups, if you're checking in. Like you said, I'm like you, I don't see a doctor more than probably once or twice a year. And so the idea but people who have chronic conditions may only need to check in and say, here's my blood pressure, or the things that you can do electronically and do medical devices. But I think that we have to be careful to make sure that's what the healthcare provider and the patient decide between themselves. Because the problem you get to, we'll say, if you have this kind of disorder, you can't, or if you have this kind of disorder, you can. And then somebody will come to us and say, well, I sort of have that, but I sort of have this, and I think I can do telehealth. And then what happens, you'll create hundreds of codes. If you talk to physicians today who deal in Medicare or healthcare providers in Medicare, they will say, if you would just ease all of the codes that I have to put forward, it would be so much easier to practice medicine. And a lot of people are getting tired of practicing medicine because what they're doing is spend a lot of time on paperwork. So we have to be cognizant of that. But my kind of vision for it is that you have a relationship with a healthcare provider, and telehealth is a part of that relationship with you and your healthcare provider, and being in their office is part of being with that healthcare provider.
Well, listen, this has been terrific. I want to tell our viewers that Congressman Brett Guthrie's district in Kentucky, the 2nd District, is the birthplace of Abraham Lincoln. You've got the Mammoth Cave National Park, and you've got Fort Knox, which I've never been to, which I really, really want to go see. You may want to mention something, but I really appreciate you joining us today, talking us through this, new evolving set of platforms out there and what the strengths and costs are. Thank you very much, Congressman Guthrie.
Well, thank you for having me.
Well, that brings us to the end of our program today. A very big thank you to Neurocrine Biosciences for its support, and all of you attendees for listening to this today. Please, go on to our website. We're going to have all of these conversations on our website shortly. Show them, share them, watch it again. I'm Steve Clements. Thanks so much. Be healthy and be well.